If you, or maybe someone you know has ever had a kidney stone, well, you know the symptoms are just unmistakable.
Oh, absolutely.
It's that really acute, sudden cramping pain, the renal colic, often starting right there in the flank. But the sort of defining clinical sign that specialists really look for
Mhm.
is that patient's complete inability to get comfortable, that constant restless movement, that desperate need to pace or shift around. The sources actually call this bewaging strain.
Yes, that's the hallmark symptom.
Yeah.
It really sets stone pain apart from other abdominal problems. You just don't see the patient lying perfectly still.
No.
They're pacing, they're constantly trying to find relief, but it just doesn't come. And, well, that level of pain, it demands really rapid, evidence-based help.
Exactly. And that's why we're doing this deep dive today into the current evidence on urinary stone disease. We've pulled from the 2019 update to the NHG standard, which, just for context, is the big clinical guideline GPs use over in the Netherlands.
Right, a very solid source.
Our mission here is to give you the sort of frontline, evidence-backed strategy for how stones are diagnosed, managed, and treated today. Really cutting through some of that, well, frankly, outdated advice.
And we're focusing specifically on that acute attack and then the follow-up for adult patients. And, prepare for a couple of genuine aha moments, I think, especially around some of the myths about drinking fluids.
Okay, intrigued already. Let's start with the basics then. Just how common is this? Is it a rare thing or?
Oh, not at all. It's actually a pretty major health issue. The incidence, so new cases, is about 3 per 1,000 patients every single year.
3 per 1,000. Okay.
And the overall prevalence, like how many people have it at any one time, is sitting around 8 per 1,000 across the population.
And there seems to be a bit of a gender split here, too.
There is, yeah. Men are roughly twice as likely to get a stone compared to women. The rates are about 10 per 1,000 for men versus 5 per 1,000 for women. And critically, if you have a family history, like a parent or sibling who's had stones, your risk just shoots up maybe 2 to 3 times higher than someone without that history.
Wow. Okay, so if you've had one attack, the information we're covering today is really crucial because of that high chance of it happening again. How likely is a second stone?
It's depressingly common, unfortunately. About 50%, half of all patients will have a second attack within just 7 to 8 years of their first one.
50% in 7-8 years. That's huge.
It is. And that high recurrence rate is exactly why treatment can't just start at managing the pain. It really has to include thinking about prevention down the line.
Okay, before we get to treatment then, let's define what we're up against. What are these stones actually made of? Where did they form?
So they typically form up in the upper urinary tract, like the kidney itself. And the vast majority, we're talking over 70%, are calcium oxalate stones.
Calcium oxalate. Okay.
Yeah. We also see things like calcium phosphate stones, uric acid stones, and then very rarely, less than 1%, these metabolically driven ones called cysteine stones.
And the basic idea behind how they form is this concept of supersaturation, right? What does that actually mean in simple terms?
It just means the urine has too much of certain things dissolved in it, specifically ions like calcium and oxalate. They're at such high concentrations that they're kind of unstable.
Right.
Now, while we know this supersaturation has to happen for a stone to form, the exact trigger, like why crystals suddenly decide to clump together and grow into these painful stones, well, that's still not perfectly clear. It's probably a mix of diet, genetics, maybe some metabolic factors.
Okay. So now let's picture the scene. A patient comes in with that awful colic pain. What are the key things you're looking for to really pin down the diagnosis?
Well, first is the location and pattern. Usually one-sided pain unilateral in the flank, the side, or maybe lower abdomen. And it comes and goes in waves, that classic colic pattern.
Right, the waxing and waning.
Exactly. And along with that, because the pain is just so intense, the patient almost always feels nauseous, often vomiting too.
Yeah. And I thought it's interesting that the source mentioned if the stone is lower down, like closer to the bladder, the symptoms might actually mimic bladder issues, like needing to go frequently or feeling urgency.
That's right. That can be a clue. The stone is quite distal, maybe nearing the end of its journey. Another really key diagnostic piece is blood in the urine hematuria.
Okay.
It's there in most cases, maybe 70% to 95%. But, and this is really important for you listening, not seeing blood doesn't rule out a stone. You can still have a stone without visible or microscopic blood.
That's a crucial point. And conversely, something that suggests it's not a typical stone is seeing actual blood clots in the urine.
Exactly. Clots usually point towards a different source of bleeding, maybe trauma, a tumor, or something else significant in the urinary tract. That needs a different urgent investigation, definitely outside the standard stone protocol.
Okay, so when someone's diagnosed, what's the general outlook? Is there hope? Do most of these things pass on their own?
Oh, absolutely. The prognosis for spontaneous passage is actually really good. Somewhere between 85% and 95% of stones will pass without any intervention, usually within about 2 months.
85 to 95%, that's encouraging.
It is, but that rate really depends heavily on the stone's size and where it's located in the ureter.
Right. Can you give us a feel for those numbers? How much does size matter?
Size is probably the biggest factor. For a really tiny stone, say 1 millimeter, the chance of passing it is high, maybe around 87%.
Okay.
But once you get up to a larger stone, like over 9 millimeters, that chance drops dramatically, down to maybe 25%. Location matters too. Stones lower down, more distal, pass more easily, maybe 75% pass, compared to stones stuck higher up near the kidney.
Got it. So even before we talk pain relief, the ultimate goal here is thinking long-term, preventing that 50% recurrence rate. And that process starts right away, doesn't it, in the acute phase?
Yes, absolutely. You have to tell the patient straight away, try to catch the stone.
Like with a tea strainer or something.
Exactly. Use a sieve, a filter, even a special collection cup. Because getting that stone analyzed is, without doubt, the single most important step for guiding long-term prevention. If you don't know what it's made of, trying to prevent the next one is basically just guesswork.
Right. Okay, let's dive into the actual management now, because this standard, the 2019 update, has some really significant changes from maybe what people have heard before, starting with immediate pain relief for that acute colic. What's the first thing you reach for?
For that really severe acute colic, the standard is clear. You need rapid effect. That means diclofenac, 75 milligrams, given as an intramuscular injection, IM.
Intramuscular, okay, not pills.
Not initially, no. The IM route is preferred right then because it works much faster than taking a pill or using a suppository when someone's in that much agony.
Makes sense. And what if diclofenac isn't an option, maybe due to contraindications, or it just doesn't work after, say, 10 or 30 minutes?
Then the next step is usually an opioid, typically morphine, given either subcutaneously, just under the skin, or also intramuscularly. Now, when you're thinking about pain relief for the patient to take home, the choice is often between diclofenac pills and naproxen pills, and that involves weighing up the risks. Diclofenac has a slightly higher cardiovascular risk profile, whereas naproxen carries a bit more risk for gastrointestinal issues like stomach upset or ulcers, so it often needs to be taken with stomach protection, like a PPI.
Right, that risk-benefit calculation. Okay, now let's hit what you called the first policy earthquake. This seems to go completely against what many of us, maybe even doctors, were taught about managing kidney stones. The advice about drinking fluids.
Yes, this is a really big shift, and honestly, it clears up a lot of old confusion. The previous advice was often contradictory, wasn't it?
Yeah, like don't drink too much at first, then force fluids later.
Exactly. Restrict fluids initially to try and lower the pressure in the kidney and ease pain, but then push fluids like crazy later to flush the stone out. The current standard says very clearly that advice is gone. It's removed.
Why? Just no evidence.
Pretty much. There's just no good proof that either restricting fluids or forcing fluids actually helps reduce pain or increases the chance of the stone passing spontaneously during that acute phase.
So what is the recommendation now? Just drink normally?
Exactly that. Advise the patient to maintain normal fluid intake. Let thirst be their guide. There's absolutely no proven benefit to making them feel even more uncomfortable or nauseated by forcing them to drink gallons of water.
Okay, that's a major takeaway. Drink normally. Now, the second big shift involves a medication often used for other things, tamsulosin. It's an alpha blocker, often for prostate issues. The standard used to be against using it for stones, but now there's a sort of weak recommendation for considering it. What changed?
Yeah, that change reflects newer, large-scale studies. Tamsulosin, usually 0.4 milligrams once a day, and it's important to note this is off-label use.
Meaning it wasn't originally approved for this specific purpose?
Correct. But it's now considered a reasonable short-term option to discuss with the patient. It's inexpensive, generally pretty well tolerated, and the evidence shows some definite, although perhaps modest, benefits.
Okay, modest benefits. What are they specifically? What might tip the scales towards trying it, even with just a weak recommendation?
Well, they're clinically relevant, I think, especially when you think about quality of life and avoiding hospital visits. The studies suggest alpha blockers likely increase the overall chance of the stone passing on its own.
By how much?
We're looking at about a 6.9% absolute increase in passage rates. Perhaps more importantly, they possibly reduce the number of pain episodes the patient experiences, maybe by about 0.7 fewer episodes on average.
Okay, fewer pain attacks.
And they also seem to reduce the chance of needing hospital admission, again by about 6.9% in absolute terms.
6.9% reduction in hospital stays might not sound enormous, but like you said, given how bad renal colic is, avoiding even one trip to the ER is a pretty significant win for the patient.
Precisely. So for a low-cost medication, used just for a short time, with generally minor side effects, maybe some mild dizziness or a slight drop in blood pressure,
Right.
the potential benefits seem to outweigh the harms for many patients. So it's worth considering, even if the evidence isn't quite strong enough for a blanket, everyone should get this recommendation.
Okay, that makes sense. Let's shift gears now to the imaging strategy, because this is another area where the approach seems to be about patience and, importantly, minimizing radiation exposure. We're not jumping straight to a CT scan, are we?
Absolutely not. The standard is very clear. Imaging is explicitly not recommended in the first 5 to 7 days.
The first week, basically.
Yes, that first week is all about controlling the pain effectively and just waiting, giving the stone a chance to pass on its own.
So you check in after about 5 to 7 days. If the symptoms are gone, urine's clear of blood, then basically case closed for now.
That's the idea. Episode resolved. But if the pain is still there or there's still blood in the urine, then we start a very specific step-by-step imaging process. And step 1 is...
Step 1 is an ecography, an ultrasound.
You're right. And the main goal there isn't just finding the stone, which ultrasound isn't always great at, but crucially, checking for dilation. That's swelling in the kidney's collecting system or the ureter.
Why is dilation so important?
Because significant dilation suggests there's a major blockage, which increases the risk of kidney damage or infection. It's a key indicator.
Okay. And what if that ultrasound comes back negative? No obvious stone, and importantly, no dilation. What's next?
Then step 2 is a simple abdominal x-ray, often called a KUB, kidney ureter bladder x-ray.
Right.
It's quick, uses less radiation than a CT. If both the ultrasound and the x-ray are negative and the pain is manageable, we generally continue waiting and watching.
So the CT scan, which people often think of as the gold standard for finding stones, is deliberately held back. Why wait?
It really comes down to radiation exposure. CT scans deliver a significant dose, so we reserve it for when it's truly needed. It's generally only considered after about 4 weeks if that initial ultrasound and x-ray combo didn't find the stone, but the symptoms are still dragging on.
4 weeks.
Okay. And even then, if the CT finds a small stone, say under 5 millimeters, the first approach is still usually to wait a bit longer for spontaneous passage. But obviously the clock is ticking by that point.
Okay. Before we wrap up, we absolutely need to cover the red flags. The situations where you don't wait, where that whole stepwise approach goes out the window, and you need to get a urologist involved immediately.
Yes, these are the urgent scenarios. They include any sign of infection, like a fever alongside the pain. That's a urological emergency.
Okay, fever's number 1.
Then pain that just cannot be controlled even with strong medication like morphine. Any suspicion that there might be stones blocking both kidneys, or if the patient is known to only have one kidney.
Right, critical situations.
Also, any sign of acute kidney injury or worsening kidney function specifically, if the estimated GFR, eGFR, drops below 30. And finally, if that initial ultrasound does show significant dilation or swelling, any one of those is an immediate referral to urology.
Got it. And even if none of those red flags are present, but things are generally okay, if a stone still hasn't passed after, 8 weeks total, that's kind of the end of the line for waiting?
That's generally the cutoff, yes. After 8 weeks, the chances of that stone passing on its own become pretty slim. At that point, referral to a urologist is usually needed to discuss options for actively removing the stone and certainly for planning long-term prevention.
This has been incredibly helpful, really clarifying the modern approach. So the big takeaways for everyone listening seem to be hit that acute pain hard and fast, preferably with diclofenac IM. Forget the old confusing advice about forcing or restricting fluids. Just drink normally.
Right.
Consider tamsulosin as a potential helper to ease passage and maybe avoid the hospital. And be patient with imaging. Follow that stepwise approach, saving the CT scan for when it's really necessary.
Exactly. And, this brings us right back to that final thought, maybe a provocative one for you to consider. We talked about that 50% recurrence rate within 7 or 8 years.
Yeah, it's quite sobering.
It is. And while all this acute care manages the immediate crisis, what really determines your long-term outlook, your chance of avoiding that next attack, comes down to the why. Why did you form that stone in the first place? And the answer lies in its composition.
Which you only find out if you catch it.
Precisely. So what does this all mean for you, the listener, maybe even someone going through this right now? It means that seemingly simple, maybe even slightly unpleasant instruction, try to fish that stone out of your urine, is actually the absolute key to potentially preventing years of future pain.
Because analyzing it tells you what type it is.
Yes. Analyzing that tiny crystal confirms if it's the common calcium oxalate type, which has certain preventative strategies, or if it's one of those rarer types like cystine or maybe struvite, an infection stone, which require completely different, often metabolic long-term workups and treatments. Sometimes analyzing a common stone even picks up underlying issues like hyperparathyroidism that might have been missed.
Wow.
So the ability to analyze that little past stone, that's the critical link. It moves you from just reacting to pain to proactively changing your long-term health and hopefully avoiding that 50% statistic. So please, never underestimate the power of catching the stone. It's the ultimate first step in prevention.